Welcome to Health or Consequences, the Healthcare and Public Health Policy podcast under Commonwealth Magazine. I'm Paul Hattis, here with my colleague John McDonough from the T.H. Chan Harvard School of Public Health. And we're delighted today to have as our guest Dr. Eric Dickson, President and CEO of UMass Memorial Health. Dr. Dickson is also a professor of emergency medicine at UMass Medical School, and he currently serves as the chairperson of the Massachusetts Hospital Association Board. And really, Dr. Dickson is a standout amongst his hospital health system and physician executive colleagues around the country for all the things he's been involved in and his wide-ranging views. And so we're very fortunate to welcome Dr. Dickson today.
Well, thanks so much for having me, Paul. Good to see you, John.
Perhaps just to get things started, can you tell our podcast audience a bit about your background and how you came to be the president and CEO of UMass Memorial Health?
Well, I like to say I'm only a physician and I'm only the president and CEO of UMass Memorial because I am too tall to be a helicopter pilot. And when I was in high school and growing up in Burlington, Massachusetts, I wanted to be a helicopter pilot in the Army. And I joined the Army right out of high school. And I had grown another inch or so, and my seated height was too large. And they said, well, you're already in the Army, so you're stuck here, but you can't be a helicopter pilot, so you have to choose another profession. And I ended up as a combat medic, which was where I found my love of medicine. And then they trained me as a respiratory therapist. And as I came out of the Army, I went through my pre-med because that's what made me want to become a doctor. I actually started at UMass as a respiratory therapist, hoping to get into med school here, and did get into med school and worked as a respiratory therapist in the hospital throughout my days in medical school, and then did my residency in emergency medicine here, first faculty job here, and basically, except for a few years at the University of Iowa, I've spent my entire career here. And now I'm in this dead-end job with no chance of moving up as CEO for the past 8 years. But I still in many ways feel like, part of the Department of Respiratory Therapy and just love my colleagues there, many of which are still here, which is also true of my colleagues in the emergency department.
So the major issue we're all still dealing with is the COVID-19 pandemic. We have reasons for hope in the vaccination surge. We have reasons for alarm, what's going on in Brazil and particularly now India. What have been some of the biggest challenges you've faced over this past 15 months in terms of it? And what are you still dealing with most intensely and most concerned right now?
I think the biggest challenges have shifted over time. The first thing was a scarcity of resources, PPE, and an ability to test patients for the disease. We didn't have the broad testing capabilities that we have now. Then as things got worse, it became ICU beds and hospital beds and everything associated with that. But we got through the first surge. And we saw a shift really towards recognition that we had a major equity issue occurring with COVID, that in our own region here in central Massachusetts, the primary issue became we're seeing Latinx populations get infected at 3 times the expected rate versus a Caucasian individual. And the same is true for African American populations. And we clearly had to deal with that, and we're still dealing with that in the vaccine situation. But I would say if you said right now, what's the biggest challenge we face? It's just how tired everybody is. Like in the healthcare workforce has been through so much emotionally, and we're all used to working hard in the hours, and we've been through residency, but we've just never seen death at this level, right, for this period of time in our careers, and death in a way that's been much harder on us. Part of our healing as healthcare workers is when we lose a patient, is helping the family heal. We try to be the strength for them. There's no family members involved. And to try to do through FaceTime or Zoom, tell someone that their mom, their dad, their son, their daughter, or husband or wife have passed away, and they couldn't be there, and you couldn't let them in. And that's been worse than the amount of work and wearing the plastic gowns and the PPE, that we just don't get the family interaction because of the infectious nature of this. And so I said to some folks the other day at a strategy retreat, we have to be thinking of the future and what are we going to do and how are we going to recover? We've got a backlog of people that need our care. And some of them said, and they all shook their heads, is, Doc, we're just trying to get through today. We're just trying to get through today. And I think that's going to play out in the next year or so. And if you're in a CEO of a healthcare system, if you're in any leadership of a healthcare system, do not underestimate how tired your people are and how important your leadership and giving them hope and taking care of them is right now, because that's your most important job, taking care of your people that are taking care of the patients.
Appreciate your sharing with us sort of the care challenges of COVID, but we also know that there's been financial challenges for a whole range of different organizations. COVID and our State Center for Health Information Analysis recently released some data that showed, for example, that your system had a negative 2% operating margin, even after receiving a little over $183 million in governmental COVID relief funds. How are you doing now financially as a healthcare system?
And I think if you look at the history of UMass Memorial, we hover around break even, and that's kind of where we're at now. We've been in existence for 23 years, and about half the time we've been in the red and about half the time we've been in the black. And that really has to do with serving a heavily Medicaid population, people living in poverty and therefore eligible are Medicaid, and payer mix for us, and also having the financial burden of having to support a trauma center, the only trauma center in the region, the only level 3 NICU, the only transplant center. And we were created by an act of the legislature, and the legislature said, you will care for the indigent populations of Central Mass, you will provide services not otherwise available, and you will support the state's only public medical school. And that's core to who we are. And I've been a part of, the organization, even going back to the UMass days before the separation occurred. But what the legislature forgot is to give us instructions on how we were supposed to pay for all that. And each one of those 3 missions that was given to us comes with a very large price tag. And what it means for us is we can keep the lights on, but the kind of having dollars to invest in new buildings and new technologies, that comes really hard to us, and has for our entire time that we're here. And we are alone in having that act of the legislature that created us and part of those missions. Other safety net providers with a high percentage of governmental payers suffer just like we do. And it's like I said, with the caregivers that are just trying to get through today, you talk about 5-year financial planning, and I'm just trying to get us through this year. And that's part of the challenge of the U.S. healthcare system overall, and certainly what we have here in Massachusetts.
So Dr. Dickson, you serve now as the chair of the Massachusetts Health and Hospital Association, formerly the Mass Hospital Association, which is the voice of the hospital industry in Massachusetts. Massachusetts hospitals over the past year got about $1.8 billion in COVID relief funds, mostly federal. What is the financial position, and how is the hospital industry in Massachusetts doing right now? Did the distribution of monies make sense to you? Was it done well? What do you see in terms of looking at the industry as a whole and what it's facing and how it needs to deal with these problems moving forward?
Well, I think if you look at the industry as a whole, you're going to see depressed margins across the country, but it's not uniform, right? as is always the case, if you look at places like Lawrence General Hospital that cares for a very under-resourced population, Signature in Brockton, Holyoke, ourselves, you're going to see negative margins and margins that are even more depressed from the safety net providers than you're going to see from organizations that had a better payer mix. And part of that is the way that the federal government doled out the money. And the $1.8 billion is a lot of money, or $180 million is a lot of money, even for a system as big as ours. But if you look at how the first and the largest bolus of dollars was given, it was given based on a percentage of net patient service revenue. So if you had high commercial rates and a high commercial percentage and low Medicaid, your worst payer, you got a lot more money on a per bed basis than the safety net providers got who had high Medicaid. And in this state, on average, Medicaid pays less than half of what Blue Cross Blue Shield, your commercial payers, and even in that group, there's marked differences between what some payers get versus others. And so, if you give out the money based on net patient service revenue, the rich were getting richer and the poor were getting poorer based on that. Now, thankfully, in the second and third tranches that came through, and I have to credit Jim McGovern and Richie Neal, two very powerful congressmen from Massachusetts that helped all of the safety nets in the country. They pushed Secretary Azar to make some of the allocation go to the safety net providers, high governmental payers, and then the hotspot money helped healthcare systems that saw a disproportionate share of COVID cases. And that aligned with seeing a disproportionate share of people of color because they got the disease at 3 times the rate. So hotspot money actually lined up quite well with safety net providers because it was the populations that we serve that got COVID at a much higher rate. So there was some improvement thanks to again, those individuals that I mentioned. But, you know, in the end, when you look at what happens in a disaster, and I'm trained in disaster medicine as an emergency physician, the poor always do worse. They don't have any reserve. They don't have any stored food. They were just hanging on right before the tidal wave hit or the hurricane came through. And when it comes through, they don't have the reserve. Whereas people of wealth and even moderate wealth and middle class tend to have some reserve they can get through. There's cash on hand. They have a car they can drive and get out of the disaster zone. And that's really what happens to hospitals in the same situation, that, you know, those that didn't have a big cash reserve and didn't have money to get through, they suffered more than those the hospitals of means. And you know, well, we'll talk about Medicare for all at some point. I'm betting, John, with you on the line and with Paul here, but that's a big part of why I'm a supporter.
Before we do that, though, let's stay on this theme of the market. And, you know, some institutions, just like people, have more resources available to them than others. And right now, the Department of Public Health has in front of it a series of DON applications, really from our, by many measures, largest and wealthiest healthcare provider system, Massachusetts General Brigham. And included in those DON applications are 3 new sites for ambulatory care expansion, including one in Westborough, sort of your neck of the woods in your service area. And I know there's been hearings about this. And if you listen to those hearings, I've tried to listen. And I know there's been a lot of different folks on the line raising various issues of concern. But let's start with your thoughts about this particular ambulatory care site expansion proposal on the part of that system.
And I think in general, if you look at healthcare in the state or even across the country, you have to make a decision as a society. If you're just going to go free market economy, everybody can compete, everybody can set up shop wherever they want. Or if from the government standpoint, you have to be involved in that decision about where you are allowed to put an MRI or a new clinic or a new hospital. And the reason the government stays involved in healthcare and doesn't just let us compete on the basis of value is that in the United States, we have cross-subsidization of especially Medicaid with commercial insured. And like if we all got paid the same and we all had the same payer mix, you could do that, but we don't. And so what happens if you allow in any region or any state a healthcare system to cherry pick and say, I just want to take care of patients in the wealthiest neighborhoods with the best insurance, and they're probably best for philanthropy as well. And I'll just set up shop here. It's always going to be at the expense of the poor and underserved, because it means that those resources are going to go preferentially to that cherry picking system away from the system that is caring for the high Medicaid population. And so that's why the state has to stay involved and has a DON process. And they have to ask the question, you know, in this particular situation with Westborough, I have a lot of respect for the people at MGB. And I think they have a great, you know, world-renowned healthcare system. And I send them patients, a very small percentage of patients that they have capabilities that we don't have. But if you let the most expensive, largest healthcare system in the state expand to one of the wealthiest regions of the state and neighborhoods of the state, we just all have to go in eyes wide open and say, boy, that's going to have a negative effect on the healthcare systems that were cross-subsidizing the care of the poor. And in Westborough, that's us. You know, if you look at
that when the state does its review, it's going to drill into the economic impacts, both on the market overall and the individual providers that might be affected?
Yeah, that's what we hope. And that's what should happen with the DON process. And that's why we have a health policy commission, right? To have this independent review and to say, you know, MGB has made the claim that this is going to lower the cost of healthcare in the state, and that, oh, anybody can come to this facility. Anybody that has a car and can navigate Route 9 because it's not on a bus route, right? And but if you're living and if you're non-English speaking and and you're living in an under-resourced neighborhood in Worcester, can you really go to Westborough for care? And I think that it's I don't blame MGB for this. It's a good strategy. They highlighted this in their presentation and said, look at this great commercial market share here, and they want to make a bridge to two of the best hospitals in the country. It's a good strategy when you think about it. But the state has to ask the question, is this the best thing for Massachusetts? Is this going to have a negative impact on other populations? Is this going to raise the cost of care in this state or lower it as they've claimed? And I look at it, and I'm biased, and say, even if I ran Berkshire and I'm way away from this and not impacted, and I look at this, I think I say, well, that's going to be bad for underserved populations, and that's going to raise the cost of care in Massachusetts, which is always top 5 in overall cost per capita of care. So we don't have room to add to the cost of care overall in the state. So I think it's bad for Massachusetts, even when I try to be as unbiased as possible, and that the state should do a thorough analysis of this transaction.
So to turn that issue around a little bit, so there's a new conversation, it appears, in the country around market concentration, monopoly generally, and focusing on the healthcare industry in particular. So the Mass Health Policy Commission recently cleared your system's purchase of Harrington Hospital in Southbridge and its related physician group. Should this transaction raise any market impact concerns? And how is this different, do you think, from the other mergers and acquisitions that have caused so much controversy and concern?
Well, I think the health policy took a close look and said they looked at Southbridge and they said, okay, out of 351 towns in Massachusetts, they ranked 342 in terms of per capita impact. And what they probably said is, why is UMass Memorial doing this? It's one of the worst payer mix in the state, which is why Harrington has lost money for 5 years, 6 years in a row. And it's because it's about the mission, right? Like that's, for Harrington to try to continue to slog along on their own with needing a new IT system, needing capital investments, needing to borrow some money, needing to meet regulatory requirements that are getting harder and harder over time, it's just hard to see them making it, given their payer mix. So we had to ask the question, what's the best thing for the people in that region? And I have to admit, our board, looked at the finances and said, boy, this is a tough one to support, but these are these people are in our primary service area, and what's the best thing for that region? And I think their board as well looked at it and said, geez, we'd love to stay independent. We like that flexibility, but their fiduciary obligation is to the people that live in that region. And that's why the Health Policy Commission said, boy, this isn't about gaining commercial market share and market dominance, because we don't get to negotiate prices with either the federal or state government. So the vast majority of the patients that will be cared for in Harrington, we don't have an ability. Market share doesn't buy us any more clout with the payers, and they did not think this transaction would add to the overall cost of care and that would be net beneficial to the communities in that region.
Is there any future at this point for smaller independent hospitals in Massachusetts, or is it just a matter of time before they are absorbed into larger systems or close?
Well, it depends on what you mean by future in terms of duration. There are hospitals that enjoy an excellent payer mix, have good philanthropic programs, and can hang on longer than others. But ultimately, it is getting so hard to have the infrastructure necessary to run a healthcare system. It doesn't make sense, right? To think about what you need for an IT system now that is state of the art, especially as we start to add artificial intelligence to help read radiology and x-rays and images and things like that, the continued subspecialization of each of the practices, you just can't do it as a small 100-bed hospital in the long term. But if you have a big reserve, then you could probably hang on longer. And that's always the case. If you have cash, you can wait. But I just, as someone who oversees community hospitals, and has usually gets them when they run out of cash, it's just a matter of time, I think. And I think the same thing is for private physicians. None of our residents go out and start private practices. Overwhelmingly, they come in and they become employed. There are some docs that will hang on, good friends of mine that say, I'm just not going there in terms of the employed model, but it's inevitable in the end.
Eric, as we move to the final phase of our discussion with you today, we really want to broaden it because you're such a critical thinker. And I know from all the things that you've published on and talked about over the years, we want to give you a chance to sort of say, here we are in 2021, at whatever stage of the pandemic we are now, and where we find the healthcare market and state and nationally, and Democratic President Biden and Democratic House and Senate and our state legislature, Governor Baker. You look at all of that, what's on your mind about important changes for public policy, federal or state, for the healthcare system in the next few years?
Yeah, I think at the state level, I look at things and I say, Massachusetts, prides itself in having one of the highest quality healthcare systems in the country, in the world. And I say there is no quality without equity, right? If we continue in this state or any other to pay half as much or less for the care of people living in poverty versus what we pay for people like myself that have good commercial insurance, you will never have equity, and you will never have quality without equity. And there is a pathway in Massachusetts to get closer to that. And what I have proposed and have talked to many of my colleagues that run healthcare systems across the state is doing what other states have done, and to get your Medicaid rates up towards Medicare. And you do that through a provider tax or a provider assessment. So you tax everybody based on their commercial rates, and those with the best commercial rates and those with the highest percentage of commercial pay more than those with very little. You give that money to Medicaid. They enjoy an excellent federal match, and they take that federal match plus the money that the healthcare systems have put in, and you work to move your Medicaid rates to Medicare. That is the first step in getting to a more equitable healthcare system. And now on a national level, if I can expand to that, why do we need 50 Medicaid programs across the United States? The reality is most of the money is coming from Medicare anyways for those programs through a series of special payments and the federal match and other ways that each state has figured out how to jigger the system to get dollars in. And if we can't have Medicare for all, and I think that's a real heavy lift, let's start to move towards that by lowering the age that people get into Medicare, and getting all of the people that we insure, self-insure at UMass Memorial, that are, let's say, above age 63 into the Medicare program early. And we would be willing to pay an increased Medicare tax because we're saving money on the self-insured program. And I think the employee should be willing to pay an increased Medicare tax because they aren't paying the 20% anymore to cover their own health insurance. So, I'm an incrementalist, not a revolutionist. I think there is a pathway in the state of Massachusetts through the provider assessment to get Medicaid rates up towards Medicare and get some greater equity in this state by leveraging federal dollars. Wouldn't even cost the general fund anything. Well, at the same time, we can start to think at the national level of slowly increasing the Medicare tax to corporations and individuals as we slowly lower the age of Medicare, and ultimately with the goal of getting to Medicare for all. And as people who understand the numbers, as you move from the 65 to 64, 63, every year gets less expensive that you want to add, right? Because the most expensive group in that's not in Medicare right now is 64 to 65, and then it becomes less and less expensive. If you can just start, you create a system that is achievable over the course of 10 years. You keep Medicare Advantage going, and because that appears to be a very good way to manage the overall cost. And we can get to an equitable system in this country, the same equitable system that many other countries have with a single payer. That's my dream. I'm 54. I get time to see this in my lifetime, maybe even in my career.
So let's just dig a little bit more deeply into that. You've turned a lot of heads all around the country by publicly endorsing a Medicare for all style framework. That position is clearly anathema to the insurance industry and others, but it's also opposed pretty strenuously by the US hospital industry. They oppose Medicare for all. They oppose a public option. They oppose lowering the age of Medicare eligibility to 60 or 55. What do you know that they don't know? And what has been the reception to your outspokenness on this in your interactions with hospital executives and companies all across the country?
Well, I think when I get this pushback, and I've had some, stones and sticks casted at me from my colleagues, and I'm often surprised taking this position that I ever got elected to be. chairman of the board for the Mass Hospital and Healthcare Association. And then I walk them through, I say, we don't have to get rid of the insurance companies. Let's have it Medicare Advantage for all, right? So now I've got a few insurers that say, oh, we'll work with that. And then I talk about the being self-insured, and I say, well, let's think about how much money your company would save if you didn't have to pay for healthcare and insurance. And would you be willing to, and well, the government can't afford it. I said, well, would you be willing to put some of that money you're going to save now into an enhanced Medicare tax? And you start to walk them through the numbers. And then I say, well, the government's way more inefficient than, everyone else. And I say, well, how much do you think the interface between a provider and a payer costs, right? Typically it's 12, 15% of the premium goes to administrative expense on the payer side. And then you're looking at 10 or 15% on the provider side for excessive documentation, denials that you're managing with, pre-authorizations. I go, what do you think the cost of that is? Maybe we can take that administrative cost and bring it down to something relatively simple, like 5%, which is probably what the combined cost is for a Medicare program. And now we have 20% that we can invest in schools. Instead of, we can invest in infrastructure in this country so that we can compete in a global environment. And so I think that, it's like anything, that you get this false information thrown out there and everybody has this immediate reaction. And our job as leaders is education. Everything I do almost here is education, and start to just walk people through. Let's ask some quick questions, and you try to lead by asking those questions. But most of the time, I'm with somebody that's running a business, and they're paying huge premium increases. And I say, overall, this system could be 20% more efficient than what you have today in terms of those premium increases. Imagine if you could buy insurance at the cost of Medicare, like what that would do for your business, how you could deploy that capital and invest it to compete with Japan, who costs 40% of what our healthcare costs and gets better healthcare as well. But you get to compete with them globally. I think when you get people to the point that it is unsustainable, and then if something's gonna happen, right? And then you start to talk about the equity piece. Can we really feel comfortable living in a society where women of color are getting mammography and at a rate of half that of Caucasian women, are getting diagnosed with cancer later because they don't have the basic health care, because everybody gets the same opportunity, but yet we don't create a system that works for them. You want to be a part of that society? Now, we have an obligation from an equity standpoint, and from my perspective, it'll make us more competitive globally in terms of the products and services we produce.
Eric, I have one quick question.
Have I sold you? Will you sign on to Medicare for All? Paul and John, have I got you coming on the bandwagon with me?
I'm there. I just think that it's a incredibly difficult political lift, and so the challenge is getting from here to there is really tough. And I respect and admire your advocacy. It's really gutsy.
Thank you.
I agree with what's been said about the value of single payer. Eric, I want to just, if I could, just ask you a quick question about your intriguing state idea. Have you modeled it out at all to see whether the redistribution of dollars would help create a more certain path for some of our more distressed hospitals in the state from the proposal that you put forward in concept?
Absolutely, because it is the distressed hospitals with the lowest commercial rates and the lowest commercial percentage that would benefit the most. And I think there's a way that we could do it where nobody is really hurt by this. Remember, if we pay into a provider assessment that goes to Medicaid, you get a federal match on that spending. So it's better than the Robin Hood steal from the rich and give to the poor. you tax the rich, but then you get a multiple of those dollars back that gives you more to work with. And Massachusetts, is a net payer into the overall federal government. So it's not like we're asking for something that we haven't put the money in there in the first place through our federal income taxes. And multiple other states have done this. And I wish it was innovative and I came up with it. And wow, Eric's a genius. Eric's a copycat, right? This is an idea that's been implemented by, Michigan, Missouri does this, California does this at a much better level. And you can get there with, almost no impact to the state coffers. And that's the best part of it for Massachusetts. Now it costs the federal government money, but we can start to deal with that on the national level. Maybe this will give them the incentive they need to start to move on the Medicare for All program.
Dr. Dickson, thank you so much for this interesting and stimulating conversation. Congratulations on all your progress and hard work at UMass and out in the Mass Hospital Association. And thanks for being our guest today. We really appreciate it. And on behalf of Paul Hattis and me, this is Health or Consequences, and we'll be back with another guest next month. Thank you.